It is a pleasure to see 103 people on this webinar at 6 o'clock sharp tonight. Good evening. This is Jane Messina. I'm so happy to be welcoming you to the second webinar that we've done here in Cutaneous recently. And it's called Melanoma at Moffitt, from the patient to the lab and back. And in our presentation, which is going to be performed by myself and members of our team, we hope to give you a hopeful idea of the explosion of knowledge in many facets of the treatment of melanoma and the important role that our research lab and our clinical researchers play in crafting not only the melanoma of treatment nationally and in the world, but affecting you as our patients here at Moffitt. And we have an all-star list of panelists tonight, present company excluded, which includes our chair of Cutaneous Oncology, Dr. Vernon Sondak. He's the Richard M. Schultz Distinguished Endowed Chair in Cutaneous Oncology. We have our chief melanoma researcher, Dr. Keiran Smalley, directing our Donald A. Adam Melanoma and Skin Cancer Center of Excellence. And myself, I'm the one that is in the lab looking at your slides. And if you've ever been a patient here, the one you may have gotten a bill from and said, I never saw that doctor. So without further ado, we will begin our presentation. And a little disclaimer. So tonight, this is a brief overview of some of the topics we've chosen to cover tonight. How common is melanoma? How has its prognosis changed and how has its treatment changed? And then we're going to talk about the role of research using tumor tissue here at Moffitt. So the next slide, we'll begin our presentation and I will hand it over to Dr. Sondak.
Thank you very much, Jane, and I want to echo my welcome to everyone and my thanks for all of you devoting some of your time to hear about some of the amazing developments that that we've seen in melanoma care. In fact, I was just doing surgery today over at our main hospital at Moffitt, and one of the other doctors came up to me and said, I can't believe how much things have changed for you guys in melanoma. He was just going on and on about how things have improved, but we've still got plenty of work to do. So how common is melanoma? Very common. Very common here in Florida. The American Cancer Society issues predictions every year, predicting almost 200,000 total cases of melanoma and over 7,000 deaths in the United States. What's really relevant is of the invasive melanoma cases, almost 10,000 are predicted to occur in Florida this year, and that is number 2 in the entire country. The only other state with more melanoma cases than Florida is California by barely 600 cases, and Florida has almost twice the population. Actually, rather, California has almost twice the population. Florida has 58% of the number of patients, yet we are right there neck and neck. That's how much melanoma there is in Florida today, and the news for the future is really sobering. We're right about here where the red dot is, but the predictions are if nothing changes, in less than 20 years, there'll be twice as many melanoma cases as there are today in the United States, and that melanoma will therefore become the second most common major cancer type in less than 20 years, 18 years from now, and the number 1 cancer type in males. Now, when I say major cancer type, that's because the American Cancer Society doesn't even keep track of basal and squamous cell cancers. They are so numerous that together they're probably as many basal and squamous skin cancers as all other forms of cancer put together in the United States. That's on top of all those melanoma cases as well. So melanoma is really common today and getting more common, and will continue to get more common unless we can really change people's attitudes toward being out in the sun without adequate protection. What about the prognosis? How has it changed? And also, how has it stayed the same? One thing that's stayed pretty constant is if we diagnose melanoma early and spot it early while it's still localized, the prognosis is very, very good. This slide, also from the American Cancer Society, breaks down the survival, the 5-year survival for melanoma patients based on whether it's localized to the skin, whether it's spread to the regional lymph nodes or to distant organs. And you see, obviously, that it gets worse when it spreads. But if it's picked up early, 99% 5-year survival. And if you take all comers all together, 93% 5-year survival. So most melanoma is picked up early and has a very good prognosis. What this slide also tells us is there are big disparities, that African American patients, even though they're protected from the sun's harmful rays and are less likely to get melanoma, when they do get melanoma and they are not immune to it, their outcome is worse at almost every step of the way, and their likelihood of showing up at a more advanced stage is greatly increased compared to all other races. And that's because of multiple factors, but particularly because of a lack of awareness that melanoma and other forms of skin cancer can happen to anybody. What about the prognosis for widespread metastatic disease? We said the prognosis, if it's picked up early, is excellent. And that was one of the frustrations, one of the powerful motivators about melanoma for so many years, led so many of us to study and research melanoma, was that if we picked it up early enough and it was right there on the skin for people to see, if we could just find it, we could take care of it. But once it spread, it was defying all our efforts to treat it. This shows where we were just 20 years ago. The slide wasn't updated to 2023, but if it was to 2003, excuse me, the curves never changed. Decade after decade after decade, we saw the same outcome. And this is measured in months. And at 12 months after the diagnosis of metastatic melanoma, only 25% of patients were alive after that diagnosis. And that was the same in 1971 as it was in 2002. The median means that half of all patients were dead within 7 to 8 months of being diagnosed of metastatic melanoma. I am very, very happy to say that these numbers don't represent the state today, because we have effective treatments for metastatic melanoma. And I'm in this slide only looking at patients with a BRAF mutation. The very existence of BRAF mutations were first discovered right around 20 years ago, and it took about another 6 or 8 years to develop, test, and get approval for BRAF inhibitors. That took almost 10 years to actually get to FDA approval. At about the same time, we were developing new immune treatments like nivolumab and ipilimumab and testing them. This slide represents some of the data from a large randomized clinical trial. And now the months are out to 60 months. Remember before, 12 months, 25% alive. In this study, whoops, went wrong way, 60% 60% of all people who were randomized to get what we call ipi-nivo, the combination of two immune treatments, if they had a BRAF mutation for their tumor, 60% of them were still alive 5 years after the diagnosis of their metastatic melanoma. And the average patient was living more than 3 years. And their quality of life was far better than it was in that previous era when the only treatment was chemotherapy. And even if they lived 7 or 8 months, most of that time was actually spent in hospice care, not even getting effective treatment. So the prognosis for early stage remains outstanding, but we've made a huge difference in the prognosis of later stages as well. And how has this happened? Where's this treatment change come from, and how is it continuing to affect how we take care of patients? Well, again, just like I said with the prognosis, for early stage melanoma, the prognosis is still the same, and the treatment is still very much the same as it was 20 years ago. And even before that, treatment still starts with surgery, wide excision, that is complete removal of the primary melanoma with a measured out margin of surrounding normal skin. And in most cases, based on the thickness of the melanoma, as Dr. Messina reports it to us, we also check the lymph nodes with what's called the sentinel node biopsy procedure. Maybe quite a few of you on this webinar have even gone through that, where we use a blue dye and a radioactive tracer to map out where the lymph nodes are, to see that blue dye going right into that lymph node, and take out only that one lymph node to determine if the melanoma is present in there. And Dr. Messina, tell us what we're looking at right here.
This is what I look at when I get the lymph nodes in pathology. We look at, we thoroughly section them, and we're looking for essentially small needles in a haystack. We have here a very small portion of a lymph node stained with 2 different stains in different colors that can identify small deposits of tumor within that lymph node. By identifying that, we know with accuracy that the patient now has stage 3 disease, and they can be have the discussion for further treatment.
Okay, and this particular slide shows how many new drug treatments have become available for melanoma patients. When I talked about the old days and what was like in the 70s, 80s, 90s through early 2000, dacarbazine chemotherapy, a very particularly toxic form of cytotoxic chemotherapy, along with interferon, were the mainstays of all the treatment. Now we've got all these other alternatives, immune treatments, BRAF targeted treatments, combination treatments, intralesional treatments, and Moffitt has had a hand in the approval of every one of these drugs, as well as a host of drugs for basal and squamous cell cancer and Merkel cell skin cancers as well. We're very, very proud of the ability of our team to do the clinical trials that it took to get these drugs approved. And I'm going to show you some clinical trial examples. I already showed you one. I'm going to show it again one more time because I love looking at this study where we tested the difference between single drug immunotherapy and combination immunotherapy. And the option was give one drug first, either nivolumab or ipilimumab, and then the other second, or give them both together. And you see that in general, giving them both together was better. But even giving nivolumab alone wasn't too bad. It was a close second and much less toxic. The combination had the most side effects. So the still today, we have to be judicious and say, can we give combination treatment to everybody? No, we really can't. Not this combination, too toxic to give to everybody. We have to be a little bit more selective. But the allure of combinations in melanoma has been strong. I don't have a slide to show it, but I will put a plug in for our next speaker on research, Dr. Smalley. We recruited him here to help us work because of his expertise in studying drugs to target BRAF mutation. And he showed that giving 2 drugs instead of 1 was a clear positive, but he could actually put 2 drugs together where they were less toxic than 1 drug and more effective. So we continue to look and search for that holy grail of combinations that are more effective without doubling or tripling the side effects. And there's a new kid on the block that looks very, very promising. This is a very recent research study Moffitt was heavily involved with on several different levels, including the very design of how the study was conducted, testing a new immune drug called relatlimab that blocks a new immune checkpoint, LAG3, and comparing it, the combination of Nivo plus Rela in blue versus Nivo alone. This is what we call progression-free survival, how long it takes for your melanoma to progress on treatment. And you see that there's a clear benefit for the combination over just the 1 drug alone. And this is the survival, 20% better survival if the patients got both drugs compared to just Nivo. But what was particularly exciting, these benefits add up to just about the same as what we saw with Ipi-Nivo, with a lower level of side effects. Not quite yet as low as just 1, but much lower. We believe that in the next few months, this may become the most common treatment used on stage 4 melanoma patients. The FDA just approved it, and we expect our first patient to get commercially available relatlimab within the next week or so. So that's what we're doing for widespread disease. But this has been so successful that we're constantly looking for ways to move this to the next level, to the next patient, and to use it more effectively. So we no longer just rely on surgery or just rely on drug treatment. We now combine surgery and drug treatment in many cases. This is a PET scan. Prior to any treatment, the yellow is active, rapidly metabolizing, highly active tumor in the armpit of this patient with a BRAF mutation, completely filling his armpit. This patient could not put his arm down at his side without pain and discomfort. And there was no real surgical option for him. So we started him on that combination of BRAF and MEK inhibitors that I said was not only more effective, but less toxic. He was the very first patient who got this particular combination we call Encobini in an attempt to shrink the tumor enough to get to surgery. And you can see here, after 6 months of treatment, the tumor, the yellow, is almost gone. The tumors are still noticeable. They're not totally gone on the X-ray, but they are improving. And even though the CAT scan didn't show the tumor was gone, Dr. Messina is going to tell us what she saw when we took the specimen out.
I have to take a trip down memory lane too, like Dr. Sondak is, over the trajectory of our careers, how we've seen so many more patients with widespread disease survive for so long. at the same time, my pathology practice has completely changed. Before it was normal to get slides such as this, which show on the left side a large lymph node taken from a site such as the armpit, filled with tumor, and have multiple nodes filled with tumor. And removing those nodes surgically was really at times the only option we had. And it wasn't a great option. The patients would end up with persistent arm swelling and all kinds of post-surgical issues. And there was no guarantee that that wouldn't come back. So this is what a tumor would look like even today before treatment. Big node full of tumor shown here on high power. And let's show you what tumors look like today after they've been treated. This just looks like big pink blob to you, but it doesn't to me. It looks like beauty. It looks like success. On the next slide, we're going to show what a lymph node that has been treated with either targeted therapies to BRAF and MEK or immunotherapy will look like. On the right-hand side, I don't know if you remember from about fourth grade science, the cell had a nucleus. The nucleus was the brain of the cell that kept it living and told it what to do. And on the right-hand side, we've got some nice alive nuclei of lymphocytes, of immune cells. And on the left, you don't see any. You know why? Those cells are tumor cells that completely died from the actions of the drug. So we call this a pathologic complete response. Sometimes the drugs do a pretty good job, but you still have a few cells percolating. We would call this a pathologic partial response. And that arrow is showing one particularly ugly, kind of funny looking viable cell. And we are learning how to translate our grading of this pathology response into more accurate prognosis, better follow-up, and tailoring the need for future treatment.
Oh, whoops. Okay, and we are moving this, as I said, closer and closer to the beginning of our treatment, not at the end. The patient I showed you and the patient whose pathology slides you just looked at, where he got the BRAF MEK inhibitor combination, that was a desperate attempt to go ahead and get surgery. We had no idea whether it would work. It obviously worked very, very well. He is still alive 8 years later on no treatment at all. After surgery, no further treatment. So he had no surgical option if the drugs didn't work. We're now using this approach in even earlier cases where surgery is still a potential option. This is a particular type of melanoma we call desmoplastic melanoma. It's very unusual in a number of ways. And one of the most striking things is how it doesn't look like most other melanomas. We're used to the ABCDs, these brown and black tumors. In this case, this black spot, that's not the melanoma. That's his scar from his biopsy. The melanoma is this unusual looking, virtually flesh-colored with tumor with all of these blood vessels growing in it right on the surface of the scalp. Desmoplastic melanoma is characteristically occurring in areas that have had very, very intense sun exposure, and that's what was happening on this person's scalp. So he took part in an extremely innovative research clinical trial where he got a single drug immunotherapy, just one drug every 3 weeks for 3 doses, and then had surgery. And after the first treatment, we could see that the tumor was dramatically less obvious, less notable, smaller, softer, and by 3 treatments, it had basically completely gone away. And Dr. Messina is again going to tell us what that looked like before and after surgery.
This is a special type of stain that highlights specifically melanoma tumor cells of that desmoplastic type, and everything that's red is a tumor cell here. It's called SOX10. This would be from a patient's tumor before any type of treatment. And the next slide, much like the last case, this is actually a skin section. This looks like a big pink band on this level, but as we look higher into the area where there was a tumor previously biopsied, we see no tumor visible, only lymphocytes that have come to attack the tumor. And the next slide will show you what that red stain looks like in a case like this. No more red. So in the prior example of the patient with the very large lymph node, we gave a drug and rendered that tumor, which was previously inoperable. We rendered it resectable safely and found out that that patient had responded very well and could give them a pretty good report card on their chance of recurrence. Now, in this case, we did the same thing and shrunk not only the patient's skin tumor, but his potentially any tumor that may have been in lymph nodes. So we're trying to put the surgeons out of business here, and changing the pathologists world for sure. But there's really a lot more to do, because not every patient responds that well. I just saw earlier today a patient who had a large amount of tumor in his lymph nodes who'd received immunotherapy, and unfortunately the tumor continued to grow. And so they had to do a very large node dissection on him. Those are the tumors that Keiran Smalley and his coworkers really want to look at, because those are the tumors that are not following the rules. They're not responding to the drugs. They're keeping those survival curves going down. We want them to stay up. So we have a very active program here in which we try to obtain tumors that are from patients that are undergoing surgery, who have tumor that who consent to have their tumor procured for research. So here's a look at that procedure actually going on inside the operating room. We have on the left-hand side, we have the nurse on the right attending to the patient, while the surgeon examines the tumor on the side table, finds a piece of it that he believes can be spared from this pathology specimen, and then hands it off to a nurse in the OR, who will take it then to the laboratory and give it to the tissue procurement team. And this tumor can be banked and preserved for future research use. We've recently done that very successfully in patients with a very rare subtype of melanoma. Dr. Sondak at the beginning of the talk was showing how African Americans have a worse survival from melanoma, and they are in particular prone to one specific type of melanoma that arises on the hands and feet that does not do well. And so this we specifically targeted to procure tumor from this type of patient, and he's going to tell you a little bit more about what they found in the lab.
Okay, great. So hello, everybody. I'd like to tell you a little about some of the exciting research that we have happening at the moment, and in particular, how we can use some of the surgical specimens that you found that you saw earlier in order to learn important new things. Firstly, about the underlying causes and biology of melanoma, and also come up with new strategies for treatment. So essentially, what you can see here is actually an experiment in which we've actually taken one of the clinical specimens that you heard about earlier, and we split this up into this single cells, and then used a very high-tech approach to actually profile each of the cells in a tumor. And here is the thing that we call a cellular landscape. It's kind of an overview of all of the various cell types that we find in a melanoma. And you can see that as well as the tumor cells here, we have multiple other immune cells and host cells and things like that. Next slide, please. And the reason that this is important and informative is it really allows us to actually learn why every patient is not responding exactly the same to therapy. So what you can see on the left-hand side, this series of circles here is basically showing you the kind of cells we find in a number of individual tumors. And you can see that some of them, which are shown here in orange, are mostly composed of all tumor with very few immune cells. But then some of the others, where you can see the shading in blue and pink and things like that, have far more immune cells. And we all already know that the patients who actually initially start off having more immune cells tend to have more favorable outcomes and also respond more favorably to things such as immunotherapy. The circles that you can see on the right-hand side is currently where our research is focused at the moment, because we have so much information about all the individual cells now in a tumor. We're trying to learn how they are interacting, because we think that learning about how the individual cells, the cancer cells and the immune cells interact with each other in a tumor are again important for determining how well a patient will A, respond to a given therapy, and B, also helping us to actually select the kind of therapy the patients should be having. Next slide, please. Oh, yep. And really the thing that we're aiming towards is this very high-tech approach that you can see outlined here, where we're able to actually profile tumors from individual patients, have a look at their individual gene expression profiles, and match these to specific therapies as well. I would stress that this is at an early stage still, where we're still kind of optimizing everything, except we expect in future that we should be able to profile a patient's tumor early on and figure out the optimal therapeutic strategies for them. Next slide, please. So although you've heard about all the exciting things that we have happening, and there has been a huge amount of progress made in terms of immunotherapy and the targeted therapy, there are still some real areas of need, which I'd like to outline briefly. The first thing is that we really need to develop more effective therapies for patients whose melanoma has metastasized into the brain and the central nervous system. As you heard earlier, although there are great successes with patients responding to immunotherapy, we still have a significant proportion of patients who actually respond quite poorly to standard immunotherapy, and new strategies are needed there. We're also working, as you heard, extremely actively to use really leading edge AI tools and informatic tools to come up with new ways of analyzing the melanomas at a single cell level, allowing us to really personalize therapies in future. And finally, there are a number of subtypes of melanoma which are far more rare, such as acral, mucosal, uveal, and pediatric. And unfortunately, for patients who have these rarer forms of melanoma, we've not had the same improvements in therapy as we have for standard cutaneous melanoma. And I'd like to end there. And I think all of us would be happy to answer any questions that you have.
Before we go into the question and answer session, and I'm really psyched to see all of the interest and all the great questions, I want to briefly introduce Mr. David Curry, who works with the Foundation and our cutaneous program specifically. So do you have a few words?
Thank you, Dr. Messina. I really appreciate everybody joining us tonight for this discovery series, where we've taken an insider's look at melanoma treatment. There's many other things you could be doing tonight, but you chose to be with us. And so we really thank you for giving us the time and the attention. We're going to have a Q&A in just a moment. But before we do that, I want to thank a couple of my colleagues who are working behind the scenes tonight, Stacy Price and Tom Procopio. They do a lot of work to make this thing happen weeks before and even a couple of weeks after. So we want to thank them. Tonight, Dr. Smalley and Dr. Sondak and Dr. Messina they've given us an inspiring presentation to see how the numbers have really come down. And the reality is, as Dr. Messina said earlier, there's still a lot of work to be done. And the only way that we can really assure that we can accelerate this important research that's happening is, well, one of the ways anyway, is through private philanthropy. And so if any of you tonight have an interest in exploring ways that you can support this important research, just please feel free to reach out and contact me, and we'll try to find some ways that you can do that. So thank you again for joining us, and we've got a lot of questions. We'll try to get to all of them. If we don't, we will follow up with you, and we will get your questions answered. But for now, Dr. Messina, I'll turn it back over to you.
Thank you, David. We have a number of questions. Many of them are sort of medically, specific questions. I'm going to try to group them into broad categories. A lot of them refer to, when do you test for a BRAF mutation, and when do you use the presence of a BRAF or any other mutation to decide what therapy you're going on if your melanoma has spread? And that is a question for Dr. Sondak, 100%.
So we tend to test for the BRAF mutation in any stage 3 or 4 melanoma. We find it about 50% of the time, about half of the time, but not randomly half of the time. There are clear patterns. The acral melanomas that you saw, the picture of one on the bottom of the foot, almost never have a BRAF mutation. Younger patients, our pediatric patients, if they have a true invasive melanoma, much more common to have a BRAF mutation, more than 50%, 70 or 80% of them do. So it varies. And so we have to test it every time. If you do not have a BRAF mutation, then we don't use the BRAF targeted drugs. We go straight to immunotherapy. If you have a BRAF mutation, you can have the choice of BRAF or immune therapy. How do we decide? Clinical trials have given us some really specific information here. If you have already got stage 4 disease, we're beyond what we're talking about surgery, we're talking about widespread disease. Several clinical trials have now shown it is better to start first with immune therapy and save the targeted therapy for if the immune therapy does not work. If it's a surgical situation like the ones that I showed, we have much more flexibility. The advantage of using the targeted therapy, BRAF targeted therapy, is it works really quickly and very reliably. the advantage of the immune treatments may work a little slower, may last longer. So what determines what comes first is the stage of the disease, the BRAF mutation status, of course, and just what we need to accomplish. And it is a very individualized treatment. And we hope that someday those individual cell maps, like Dr. Smalley showed you, we'll be putting those up on the screen and saying, oh, of course we need to start with immune therapy on this patient. Look at how orange that tumor is. It's all full of immune cells and very little cancer. Here's another one that has almost no immune infiltrate. We've got to do something else besides immune therapy before we get started.
What about clinical trials? Do you have to exhaust all of the therapeutic approved drugs before you go to a clinical trial?
Great question, and the answer is absolutely not. Every one of the pictures that we showed, both of clinical trial results and those patients that were all the patients that I showed you were on a clinical trial, and none of them had had any prior treatment before going on that clinical trial, whether it was the individual cases I showed or the aggregate group of data were all in previously untreated patients. So, of course, a patient who is showing up for the first time with melanoma has not had any treatment, they have a lot of options now. They can get standard of care treatment. And sometimes they just say, you know what, I'm just going to go back to my local doctor, work in concert with the Moffitt team, but have my treatment closer to home. But if they want cutting edge treatments, and if there's a trial that matches up with them, then they can go on that no matter where they are in their melanoma journey.
It's given the phenomenal success of immunotherapy, and it's some, I have to stress, because somebody called out in the Q&A, why are we not talking about Keytruda, which is another immunotherapy? I think you could generalize that pembrolizumab experience to the nivolumab experience. Given the phenomenal success of those, it is harder to recruit patients for clinical trials because they just have such a good chance of success with those.
Sometimes it is, and it certainly has affected many people. We've remained committed. Let me address that because I saw those questions as well. We use, when we give talks, when we speak among ourselves, we use what we call the generic name, the official name that the NCI has given to a drug. Names like ipilimumab, pembrolizumab, encorafenib, dabrafenib, these are generic names. The company that markets the drug comes up with a catchy name that goes on the TV commercials. Yervoy is the same as ipilimumab. Nivolumab is called Opdivo. Opdualag is the name for the combination of Nivo and relatlimab. Pembrolizumab is called Keytruda by the drug company. Of the cases that I showed you, the desmoplastic melanoma received pembrolizumab on a research study, so he got true pembrolizumab, not commercially available Keytruda, but the exact same thing, just the label on the bottle is different. So there are minimal differences between nivolumab and pembrolizumab, and cemiplimab is another one. They're identical agents formulated a little bit differently so that the timing of treatment may be a little bit different. You might give it every 3 weeks or every 4 weeks. The treatment is doing the exact same thing, stimulating the immune system the exact same way. That's why we don't spend a lot of time talking about, oh, this drug or that drug. These immune drugs, we're all trying to get them to do the same thing. One other question that I saw in the chat, that since I'm talking about the names of the drugs, we know that these drugs have specific immune targets, PD-1, CTLA-4, LAG-3. What is surprising is you don't have to have that on your tumor to have the drug work, but you have to have the BRAF mutation on your tumor for the drug to work. Your body doesn't have the BRAF mutation. In breast cancer, if somebody says, oh, you have the BRCA1 mutation, that's in every cell of your body, but your breast cells are particularly susceptible to turning into cancer. In melanoma, we believe that somehow ultraviolet light or something else has damaged the DNA in that tumor, caused that mutation, even though your own cells are normal for that gene. And that's why these drugs selectively and effectively kill the tumor. The immune system recognizes the tumor as foreign, and if we can boost your immune system enough, that helps get rid of it. Even if you have side effects from your immune treatments, that sometimes means we've just revved up your immune system so high that you don't need anymore. A lot of people do have to stop taking the drugs. It doesn't necessarily jeopardize their chance of responding. Doesn't guarantee it, but it doesn't jeopardize it.
There's been a couple of questions related to people that may not be able to get the full dose of full multiple dose course of immunotherapy or targeted therapy. Do we have any separate survival data for patients who did not complete therapy? And what is complete therapy? When do you know when to stop the patient's responding?
As I said, everyone's immune system is totally different. The example I always get, in the pre-COVID world, two people could get the flu and in the same family, and one is flat out on their back in bed and the other is saying, get up, it's not so bad. And it's almost always the wife saying that to their husband. And it's not because they're bigger, stronger, they weigh more. There's nothing we can use that measures exactly how strong your immune system is and how well it will react to these drugs. It's a big unmet need for future study. So if we give treatment at the same dose to two people and one has a lot of side effects, it often means that we're going to stop and not give them any more, but it doesn't mean they won't necessarily respond. Some people actually thought that we would find that those people respond even better because their immune system is so revved up. I'm not convinced. The data is not convincing that they respond better, but it's convincing that they do not respond worse.
I don't want to put Dr. Smalley on the spot, and this is a little bit of a selfish question to put this to you, but the very provocative question is, why does immunotherapy work well for some patients and not for others? And the answer to that is really it was one of the questions that he highlights that still needs to be answered. And it's one of the holy grails left remaining to be answered for melanoma research. So I want to know why you think some respond well and some don't.
There can be all kinds of explanations, I think. One of the popular explanations can be the number of mutations that the tumor has, because there has been a link between immune responses and the number of mutations, for sure. Aside from that, it can be other things which are kind of a little harder to explain. It's like some of the melanomas we saw when we did our single cell analysis they kind of had a state where the immune system was unable to see them. They hadn't expressed things like MHC and things like that. So, I think it's really complicated. As you said, it's the holy grail of a great deal of research happening in this space. At the moment, I wish I had a clearer answer for you.
No, we showed several cases where patients received immune therapy before surgery. So that raised a couple of questions from the audience about, which comes first now? What specific situations do we give patients immunotherapy before surgery? My answer would be a clinical trial if you have desmoplastic melanoma.
Sure, right. So the desmoplastic work was entirely done on a clinical trial, and that clinical trial was so successful, it's going to be presented at the major national international oncology meeting, ASCO, just next month, less than a month from now. They may well be showing that patient's pictures in that presentation. And I think that it is an example of how the success in a clinical trial is changing practice. We talk about practice changing clinical trials. That's one. It's convinced us that we can use immune therapy in desmoplastic melanoma patients anytime we think it could make the surgery easier, more limited, or avoid another form of treatment such as radiation and so forth. So it is still, as I mentioned earlier, very much a judgment call. We didn't talk about the clinical care side as much in today's webinar, but every one of the patients that we showed you on getting neoadjuvant, that is pre-operative treatment, was discussed extensively at our tumor conference, with Dr. Messina showing the pre-treatment biopsy, with our looking at the pictures and x-rays and scans and going over what are the surgical options if we don't use treatment, what's their BRAF status, what can we expect for treatment, how long should we treat them before surgery. And so it's a team decision. It's not just the surgeon, it's not just the medical doctor, it's the pathologist, the radiation oncologist, everyone weighs in and we make a team decision. And I think in the near future, it's going to stay that way. An individual personalized decision made by a team of physicians and not by any one doctor. And we can't say we're unique in that at Moffitt, but I will say that it is absolutely ingrained in and fundamental to the way we take care of patients.
Now, we've talked a lot about systemic therapy. We had a question about TVEC, injectable therapy. Do you foresee a place for it working in tandem with systemic therapy, or is there already a possibility?
There have been many trials of that because that makes a lot of sense. TVEC stands for telimagene laherparepvec, and once you say that once, you know why that we use that abbreviation, because nobody wants to say that twice. But it makes sense because TVEC works by causing immune cells to rush into the tumor that you inject, and we think it might be able to stimulate the immune system even more. The combination trials so far have not been convincing, have not been impressive. In many cases, they've been disappointing, that it may make as much sense to do these sequentially. Just inject today, see how much benefit you get, use drug treatment later on. This is one area where we have not yet found the ideal combination. Maybe it's the sequence, maybe it's the timing, maybe it's other factors that we don't yet understand. We are still doing a lot of clinical trials combining injection directly into the tumor with intravenous drug to go through the whole circulation, because it's such an attractive and logical approach, but we haven't figured out how to do it right yet. I'm quite convinced that our trials yet have not gotten us the answer.
We had a couple questions related to early melanoma, and one of them was, is there anything new in the area of prevention? And I don't personally know of anything other than, the good old fashioned slip, slap, slop and wrap, hide yourself from the sun in the peak hours of sun, wear protective clothing, gear, and sunscreen.
Those
else
are the
that I've
most
missed?
important things, combined with early detection to protect yourself from the sun and to get your skin checked regularly and to get anything looked at if it's abnormal on your skin. I think there's a lot of research going on. I think there's research going on into better sunscreens and even into after sun approaches that could say, all right, I've been out in the sun, I got a burn. What could I do to protect my cells from that damage? Today, nothing. Once you got that burn, the die is cast, the damage is done. So there's a lot of research going on. We at Moffitt, I think, are involved in that research, but we're also doing a lot of research in early detection because we still believe that not everybody is hearing our lessons. A lot of people are getting out and getting too much sun. So we need to continue to look for ways to detect melanoma earlier in people who have been exposed to the sun.
I wish we had Dr. Nevis here to talk about some of our options for better detection of patients who are undergoing serial skin biopsies and detection of new lesions, because we do have some. We have a patient in the panel who is undergoing serial skin examinations with photography. Dr. Sondak, can you talk a little bit about where that program is potentially going here?
We're continuing to look into new technologies, new techniques, new machines. This area is advancing so quickly that somebody buys a machine and says, this is the greatest thing. It's got 96 cameras and it can work in 2 minutes. And then somebody else says, mine has 200 and works in 1 minute. And we are, the bottom line is cameras, which use the visible light, can see only so much. They can see what maybe you can't see because it's on your back or on your earlobe or something, but we're also interested in other forms of cameras, if you will, that see in a different wavelength, confocal microscopy, and other forms of imaging that can help us look at something that we think with the naked eye is fine and find out it's melanoma or vice versa. So we got a lot of stuff going on. Would be another hour to talk about all of it, but it's very much at the forefront of what we're interested in. And Dr. Rogerio Neves, who's a plastic surgeon and our newest recruit to the Cutaneous program, is heading a lot of those efforts.
Speaking of hour, I think we are at the top of it, and I think we only nipped the surface of the questions that we had. But I want everybody who sent questions to know that we will be reviewing them after the webinar and responding to you separately. And so don't be offended if we didn't get to your question. We will try to answer them all as thoroughly as we can. I want to thank everyone for your time and attention spent with us and your interest in Moffitt today. And I wish everybody the best of health.